Okay, so I'm going to be doing NG tube placement. We're placing a Salem pump and we are connecting it to intermittent suctioning. So right away before I even go in my patient's room, I want to check the orders, make sure that we are ordered for a intermittent suctioning, and we kind of question continuous suctioning because it can get stuck to the abdominal wall and that can cause more harm than good. So we want to assess things like our patient's abdominal status, what their abdomen looks like, how it feels, things like bowel sounds, if it's distended at all, things like that. If my patient's feeling nauseous, which my patient is, and that's why he's getting the NG tube. So now I can gather my supplies and head into my patient's room. All right. So I'm going to want to assess my patient's level of consciousness. So hi, my name is Demi. I'll be the student nurse that's working with you today. Can you tell me your name and date of birth? Good. So I remember coming in before, we were talking about how you were feeling pretty nauseous. And while I'm doing this, I want to assess my patient's level of consciousness, make sure they're on board and understanding what I'm going to be doing to them. I'm here to insert the NG tube. So this is the tube that's going to go in your nose and to your stomach, and it's going to help get rid of some of those juices and things that are causing you some nausea and things like that. So I'm going to explain to you what I'm going to be doing. So I'm going to be taking the tube and I'm going to have you tip backwards, tip your head back, and I'm going to put the tube in, and then once I put the tube in, I'm going to insert it to the back of your throat. And once it's in your throat, I'll have you tip your head down. And when your head is tipped down, I'll be having you drink. And as you're drinking, I'm going to keep continuing to push the tube in until it reaches your stomach. And then once it's in your stomach, we'll connect you to the suctioning, and we'll get those juices out of there and help you feel better, okay? Does that sound okay with you? Okay. And I need to tell you up front that it's going to be pretty uncomfortable to have this procedure done. But once it's done, it will be very beneficial and you'll feel much better. Okay, good. So I'm going to start by washing my hands. Get my gloves on and getting my supplies all together. So what I'm going to do is I'm going to measure my patient after I take a look at his nose. So I saw you didn't have any history of any nose procedures, no surgeries, nothing like that, no deviated septum. Is there one side that you can breathe better out of? No? Okay, good. So one thing I can do is I can place my finger here, have my patient blow out of this side, place my finger here, have my patient blow out of this side. Could hand him a tissue, let him blow. But for this, we're going to go ahead and put it in on his right side. So what I can do, I can go ahead and measure. So we'll measure from the tip of the nose to his earlobe, and then from his earlobe to his xiphoid process. We're at about 52. And the reason we want to measure is that so we can mark on our NG tube where we want to go into. And this way we don't forget. Really there's numbers on here so we don't have to mark it, but it makes it much easier to remember for proper placement. Okay, so we've got that marked. So I'm going to go ahead, place it over here for now. And I'm going to go ahead and attach my syringe right to my NG tube. That way I can aspirate right away later. So I can go ahead and drape my client, because this procedure can get a little bit messy. And I'm going to apply the lubricant. We want to use a water-soluble lubricant. when we really do this, but for practice reasons, I'm just using some celery water. Okay. So again, you remember what I'm gonna be doing. I'm gonna have you tip your head back. I'll put it in just a little bit. Have you tip your head down, tuck your chin as you're taking sips of your water, and I'll advance the tube. Okay. So you're gonna feel it going in. I know it can kind of tickle, feel a little bit uncomfortable. Okay. So we're into the throat. Now I'll have my patient tip his head down. It was tipped back before. And if I had a buddy in here to help me, they could be holding the cup for my patient, or my patient could be holding it themselves. But we have him be taking sips of water. And when I inserted this, I followed the nasal floor towards the ear. And now my patient is taking sips of water, and he's leaned forward with his chin tucked. We go ahead and advance 2 to 4 inches, making sure we're not coiled in the back of the throat. Good. Okay. And my patient started gagging. We could go ahead, take a break, have him take a couple breaths, a few sips of water, things like that, kind of calm him down and get him back in the right mind of getting the tube inserted. So now since we have it inserted, we can go ahead and aspirate some gastric secretions, check our placement, which I did get some secretions, and the color we want is like a green, a dark green, so this is good. I'll go ahead and place this right into the basin so we can test the pH. And I'm going to pull back 30 milliliters of air and connect that. And quick open a pH strip and check the pH. Okay. So our goal pH would be between 1 and 4.5 because our stomach is pretty acidic. So I tested my strip, and we'll just make sure that it's between 1 and 4.5. And for practice reasons, it's really not, but we'll pretend that it is. So now I have my air in there. Go ahead and put my stethoscope on. And then I'm going to listen to see if I can hear the air, kind of a whooshing sound coming through the abdomen. Okay, so I heard that. And for textbook standards, we say that the pH testing is the best option, but really X-ray placement would be the best option. And if for whatever reason it said we didn't get any drawback when we drew for the pH, or we couldn't hear it, we could advance 2 more inches and then redo the test to see what is going on. So I can go ahead and detach my syringe. I'm going to go ahead and connect my anti-reflux valve for now. And I can go ahead and connect my blue pigtail. Really what my blue pigtail is for is just air. Nothing gets pushed in or drawn back from this. And the anti-reflux valve just helps maintain pressure and helps our patient reduce nausea. So I have my tube placed in. I checked my placement. My placement was good. So I can go ahead and take my piece of tape and put my tape right on my patient's nose and apply my tape to nicely secure my NG tube, making sure that it's not shifting around at all. Go ahead and undrape my patient now. So if my patient had some clothes on or a gown on, I could take my safety pin and I would safety pin this to his gown, making sure he has enough room to lift his head up and down, side to side, kind of move around a little bit, and that way the tube wouldn't migrate when he's moving around, it wouldn't pull at all. Okay, so for practice reasons, I'm just taping it on there. And then one thing we would do is we would take our little connector device and we can connect our tubing to our suction, which at the hospital would be a wall suction unit. And then we'd go ahead and turn it on because we did confirm placement. And then I would want to assess how my patient tolerated the procedure, how he's feeling now. We could see the coca coming through, and I told my patient he would probably be feeling better once the secretions were coming out, so we could fill up the canister pretty quick depending on how much is coming out. If my patient had any ice chips, we would want to document how many he had, because that will mess with the suction amount. I want to document my patient's nair, which one I ended up placing it in, and I want to document things like any redness that's there, swelling, inflammation, if he's having any pain there, which he really shouldn't be, it should just be a little bit uncomfortable. We could put some Vaseline right on his nose to help the skin, and then we want to remind our patient that every day he should be getting it washed with warm soapy water, making sure that the tape isn't like falling off his nose. We could clean with some alcohol prep pads and then use some skin prep to really make sure that the tape is stuck on there. And that's what we would want to be teaching our patient, and those are some things we want to be documenting. We'd also want to document if we are connected to intermittent suction, which in this case we are. And then just ask our patient how they're feeling, if they're feeling better, which my patient says he's feeling much better now despite the tube down his throat, which patients will say that they're uncomfortable with the tube, but they shouldn't be having any pain with the tube. Then I'll go ahead and take my supplies out, perform hand hygiene, and that's it.